record these sessions so that you can also share them with your applicable team members as needed. And if no one objects, we will continue recording. If you'd like to object, please come on mic and say so, and we will stop recording. Okay, nobody has objected. I'm going to make sure we've let in everybody. Jeff, are you monitoring letting everybody in? Thank you. That's perfect. All right, folks. Well, it's been a busy week. I think I've seen several of you in several meetings this week. I'm hoping that we are all getting this shared sense of a lot of activity to move in time for January 1st. I so appreciate everyone's collaboration on this front, and I hope you feel like the department really is extending itself to significant degrees to try to land as best we can at the launch of some of these activities with the insights you folks are uniquely able to bring to the table. With that being said, I think that for today, we mostly have updates on prior conversations that we can provide based on some of the additional research and work we've had within the department and with you folks over the past several sessions here together. Before we jump in, is there anything that anybody wants to surface to make sure we get to within today's meeting? I'm going to put them in the chat so I don't miss them. If you have anything in particular that you want to make sure we definitely get to today.
I think we still need to nail down the final details so that we can access the intake directed payment incentive.
Okay, thank you. Anything else? All right. Thank you, Jay. So let's start there. I believe what we had last talked about is that the mobile crisis services, because they're under fee for service, that they would not be able to trigger a payment under the same day, next day. We did meet internally in the department and we went through federal regulations. And there are a couple of factors associated with why we can't do that were not present with when we used to be able to use mobile crisis services as a qualifying event. One of the reasons why we used to be able to do it is because it was covered under managed care and the payment was made on it, and the cost factors associated with mobile crisis services were incorporated into the department's payment to the managed care organizations, their rates. So that's a federal requirement. If you're doing a directed payment out of managed care, the dollars for that have to be baked into what we're paying the managed care organization. So at that time, when we had only 3 regions providing mobile crisis services, we were compliant. When we transitioned to moving them into fee-for-service, because we launched them statewide, we, unbeknownst to us, we hadn't realized, because we had already had mobile crisis services, it was just an expansion. I don't think it occurred to anybody that, oops, by the way, there's this little federal regulation. So that's why there were some encounters that still trickled through, but looking at the encounters over the past year, in particular, as you folks had shared with us, many of the centers are not using a mobile crisis service for that initial same day, next day service. So we don't see it as a large implication, and we're not concerned about going retroactively back to try to reconcile anything associated with that. Additionally, even though we have some CMHCs that are becoming CCBHCs and launching as of January 1st, some of the mobile crisis services are covered under the PPS model, which would mean covered under managed care. For the other 8 CMHCs, they're not covered under managed care. So there's also a federal regulation that involves the directed payment being paid out against the same class of providers. So we can't include it even now for the CCBHCs because you're at your core a class of providers of community mental health centers. That's where this actual service, originally was launched. So we can't allow it to be counted under the CCBHC model, but not under the CMHC model. So we will look at the 9-1 forward, not including it as a triggering event again, because we're having this discussion in October. We still don't have CMS approval for it. We're not going to worry too much about if something already got billed or used as the same day, next day. When we release the guidance, just look forward and we'll take it from there. Now I'll pause there to see if, and I know, Jay, that your question was about the timely access. I'll piece that together in just a moment, but for now, does anybody have any questions with what I just shared or comments?
Thank you for the explanation, Diana. It resonates well for me now. The before and after of managed care.
Thank you. Okay, now how the crisis service applies to the timely access, right? So remember how we talked about if a mobile crisis team is meeting with an individual after the individual is a bit stabilized, if the mobile crisis team is asking the question, would you like to receive services at the community mental health center? We can get you scheduled for an appointment. That could start the clock because that is not the payment trigger. The payment trigger is when the actual intake would happen within 30 days. And that is covered under managed care. So we don't have any issues with that. So we will be, the guidance will show that those discussions, that all that list that we had in the PowerPoint that we've worked on together over, I think, a series of 2 or 3 weeks, those will all be spelled out to make it clear that the mobile crisis, sort of, I'm just calling it ask the question, can start the clock for the timely access. With respect for the community reentry program, for our discussions as well, that initial appointment, the pre-release appointment, which we will stand up the code, I think it's T1023, that will be the screening, the behavioral health screening, to ensure that we're making that in-reach to the person through telehealth again. That will not start the clock for timely access. For our discussions with you folks, we will ensure you get a notification the day the person is released, and that will start the clock for the intake to happen within 30 days. So as long as you folks work to try to get that appointment scheduled within 30 days after that release and the person shows up and the intake happens, that would complete that qualifying event. Now, as you folks pointed out, if the person does not show for their appointment, you can start the clock over when they actually do try to get a scheduled appointment again. We want to hold the centers harmless if the individual doesn't actually show. So you'll be able to restart the clock. I'll pause then to see if anybody has any questions.
How does that work in an open access environment?
We had that, the open access environment, if the person comes in on open access and they receive the intake on the same day, that will qualify also.
So specifically though to the community reentry, so whatever day they show up, that's just the day the clock starts. That no matter what,
Well,
they
that's
will
the
need it because
community
there's not an appointment
Oh, because some centers don't make any appointments at all?
for open access. This is open access time, and
I think that's a
then my
little,
further. Go ahead.
I think that's a little challenging from the department's perspective because the intention is the person walks out with their plan of care and their appointments that the managed care organization has to navigate. And I think that's why we landed on notifying the center the day of release as a sort of bridge for the open access centers. And I saw somebody else a moment ago who looked like they were ready to speak. Do you want to go ahead? Lori, sorry, thank you.
I have a question, but it relates back to the mobile crisis one, so I'll hold that until
Okay.
this conversation.
Okay. So Jay, I think that's where we had landed on the open access, like well, we don't want to leave it completely open-ended because we do want the person to come out with an appointment.
So if, okay,
All right.
I guess we would say your appointment is at the open access on, say, the next business day is Monday. And if they don't show up on Monday, then when they, so it's not necessarily a specific 2 o'clock on Monday. That's just, this is the window on Monday. And if they don't show up, then you get to restart whenever they do show up.
I think logistically that might be hard for you folks to be able to maintain the data, but I think it makes sense how you describe it. Does anybody from the department have a concern about that working from our perspective? No, sounds like it's a reasonable approach.
Thank you.
Lori?
Yes, I just want to make sure I understand clearly back to the example of mobile crisis, not counting towards the timeline. It sounds like when mobile crisis asks about referring for services would be the start, and then 30 days from then to the evaluation. But how is it going to be tracked when mobile crisis asks the question? Where's that data going to come from?
So I would prefer it comes through the closed loop referral solution. So essentially you're making a referral within your centers, but I understand that your centers may each handle the communication of that in some other way. I think that I heard one center talk about that, it has to be that you would consider that a qualifying start of the clock, even for the CCBHC model, because the person has told one of your staff, yes, I'd like to get services from you, which is essentially triggering that CCBHC requirement at that point. And other centers had also talked about sort of the open access pieces of it. Yes, if they want to, they would tell them that the person, here's your hours to come in for this appointment. But I don't think we've talked about how you would document that, because I don't think you would all put it in as necessarily a Phoenix code. Kelly, are you
Yes,
jumping in to add into this? Or a separate issue? Okay.
Yeah, I think that needs to be clarified how you would know, and we can document about how do you get that data about when the clock starts till the evaluation time.
How we want to see it documented?
Yeah, what will you use to start the clock?
Like Diana, that is my question. I mean, it's one thing, like we've made some progress, I feel like understanding what's countable, but we don't know what the source of data is. And without the source of data, we're still at a disadvantage on gathering what you need to make the calculations for our payment.
Okay, so
Mhm.
that's why I'm asking sort of what would you normally use? My preference would be the closed loop referral solution, because the mobile crisis teams will be using that to facilitate follow-up services as well. So they could have a use case that we developed specifically for this that would indicate acknowledgement that the person wants to apply for CMH services. We can take that back into the specific crisis group that are working with our vendors on developing those workflows. Jeff,
That-
do you recall if we have anything specifically on a use case scenario about the person connecting to ongoing CMHC services rather than just connecting to follow-up crisis services? And I see lots of hands raising, so if this is part of the conversation, just jump right in.
Diana, this is Heather Gagnon. I just wanted to say that with Brian Harvey and that whole use case with the closed loop, we have only talked about people that are current patients, not new. So that's going to affect this conversation.
We do have our intent for the referrals to be for the new. We've had some additional meetings with some CMHC representatives as well.
Yeah, the last meeting I attended this week, we had still talked about just patients that are currently with us.
I don't know that the department can support that. I mean, it's a significant timely access payment that we have asked CMS for to open up access to services, and bridging the CCBHC standards for timely access with our goals under directed payment and community reentry and crisis services and our Mission Zero work. You know, when a person is acknowledging they want to receive services from a community mental health center, regardless of which way, of which staff person they're telling, I think we feel pretty strongly about that, but we can take it back.
I think there needs to be a conversation with Brian Harvey and the CIO group if we're going to be using the closed loop differently than what we've discussed.
Yeah, I think the other thing, Diana, I think the reason I know that I pushed back a little bit on that with Brian as well is that this potentially is a resource thing, right? The lack of integration on these things requires someone to pull that information off and then direct it into our electronic health record to the clinician, to the thing. And we don't know the flow of that. And so starting with existing clients, I'm not saying forever, but to understand the workflow so that we can understand if I have to add another position. And that's the reality. We already have people assigned to doing this so that there's real time, you know, a clinician gets the notification or the intake team or whoever it is that needs to get this so that we can then do what we need. So I think it was just so that we could understand what might be needed from a resource standpoint and to work out the kinks with people that we already know. So I think that was kind of our conversation, at least at the last meeting I had with Brian Harvey.
So I think that there's a difference between us developing the use case and with our vendors building that capacity in, and the center's capacity to resource somebody to do what you just shared, Patricia. This is only about, at this point, what we're talking about is about the directed payment use qualifier. And if a center isn't using, you know, an effective data means to document that that ask was made of the person to start the time clock, it doesn't penalize you, just doesn't position you to get a qualifying directed payment for it.
I feel like I'm really, really confused. And so I ask for everybody's grace and feel free to take me to
They're
school.
with you.
Take me to school and straighten me out, everybody. But part of me hearing the first part of the conversation is going, okay, I do have a change in workflow that we need to bring back and talk about at CLM as specifically as it relates to all of that follow-up. And because we are using our team at times to do some of that. And, you know, how I interpret it is when we're not using those triggers, those mobile crisis triggers or stabilization triggers as part of the directed payment, and I understand why, then the intent really is to try to incent me to do services differently. That's why we put these in place. And so now I have this whole workflow trying to figure out in my mind that what we're going to do in my shop to separate and divorce everything for that follow-up directed payment from rapid response. But now I hear you saying, but we want you to use the technology that we're making available to rapid response. And we're going to have a conversation with the rapid response people. And all of that conversation, my committee's having that whole conversation for me. Don't look alarmed. I gave you the warning that I'm confused, but somebody is going to have to take me to school because I really don't even know how to address it now.
So I'm kind of in a little bit of the same place or a similar place, Kelly, because right now, what process do you have for your mobile crisis teams to tell you we have a potential new client?
So Diana, those processes are going to be internal and they're going to be different for every center, but no center that I'm aware of is thinking that internal referrals are managed through the closed loop referral system, because that would require us to step outside our EMR, which I don't believe anybody at this point is considering. So I'm a little lost. I think we're talking about like 3 different things here. And maybe that's the point Kelly's making, or maybe I'm missing it. I'm not really clear at this point.
And
So I'm trying to
just-
respond to how we want to how we want you to capture the data. So we've already had the conversation, and I thought came to agreement that when a mobile crisis team has that conversation for the person, and the person is saying, yes, I want to get services from the community mental health center, that could start the clock. So I think the question we're trying to have, and again, separate from the use of closed loop referral, I suggested it for starting the clock, that being able to capture the data to start the clock. If you guys don't want to use the closed loop referral for the data source to start the clock, what do you want to use?
Well, and can I also clarify, has for the intake incentive, have you pushed that out to January 1st, or are we going to be scrambling to look back to September 1st, the original effective date?
If we want to capture the payments for that quarter, we're going to end up looking back. Not dissimilar to other years as we wait for CMS's approval. And we did submit on time, folks.
But I think your question is the question we've been asking you for a few months or a couple months or since beginning August. What is the specification that you're going to use to measure this? And today, now it feels like we're hearing, we're going to use Unite Us. And so we're a little bit surprised about that and going, yeah, well, we don't use Unite Us for that.
We don't
Well,
use
I-
Unitas.
I think it goes
I'm-
beyond it goes beyond the mobile crisis, though. Because you even on any of these, you have to report the request date. So take it out of that. It's how are we reporting that, right? Because you could put the mobile crisis ones, you could use the same way of doing it, but I don't think we've resolved how we're reporting that initial request on any of these.
I would agree, Chris. This is why I'm saying what do the centers want to use to be able to document that the mobile crisis team received that answer?
This goes
Because
beyond
Patrick,
mobile
we
crisis.
capture that, right?
But yeah, so I think that one of the things here is we do capture distinct pieces of data, and those distinct pieces of data are captured from multiple sources. We could have been notified by like the closed loop referral system. We could have been directly called by somebody. The hospital might have had an interaction with us where the client was involved. There's all sorts of ways we might capture it. Then we put that data into our system. And so we have the date of request for access, for example, right? And then we treat that as a center as a distinct piece of data, but I'm not sure you can say that we can always get it from this or we can always get it from that. We can always have it in our system and always report it out if that's the request. I believe, but again, I don't want to speak for the entire, my intent is not to speak for the overall group, but I think that we can all commit to having defined dates that we report to you, if that's the request. How? I think that I'm not going to speak for the centers on that one. I think what I would say is we've been talking about that. We can get back to you on it, I believe, as a group.
I think you're
Yeah.
right, Patrick. That's my sense as well.
That's fine. I think we're open to however you folks need to be able to document the start of the clock. Because you'll have to be able to report it to us, right? Obviously we'll be able to find the data about was the intake delivered within that time span, right? And I agree, Chris, the question of starting the clock is larger than mobile crisis, but this particular question was specific to the applicable qualifying event as associated with the mobile crisis team. That's the one
Yeah, I
that,
understand, but if we figure out how we're going to report the rest of it, I think all of us within our EHRs can log that same date and report it in the same way. I think
Okay.
we're complicating it by trying to make mobile crisis something different.
I'm game with that. So you folks are going to sort of huddle together and then come up with an approved, a preferred approach for how you'll document the start of the clock from a data perspective. Okay, I'm
Right.
seeing shaking heads. That's good. The separate question about building the use case scenario for the new client referrals to come through, that can be a separate discussion not associated with the directed payment if that's not what you folks want to use for the data source. And in terms of building the new case referrals, right? I think we probably still need to complete pursuing that from a contractual perspective with our vendor and socializing it across the centers, and those who start using it, and those who don't. Certainly we don't want to overwhelm everybody, but we also don't want to miss capturing the data of when those instances are indeed resulting in people wanting to onboard to the center services.
Diana, what was your second example? You said you acknowledged that the CMHCs are going to reconvene around what will be the field they report for application of service, but what was the second scenario?
I said that we would be able to obviously capture the ending of the time clock based on our getting the starting dates and us querying the system to see that the intake happened within that 30 days. We'll just have to build a specific query for that. Was there anything else we wanted to try to, I'm going to put also in the notes here. Sorry, I said now, but I'll also put in the notes there so that it's easy to see on the Teams chat. That also CMHCs will develop preferred. Okay, anything else on directed payments? All right, thank you, folks. Last week at the end of our meeting, I had said that I was aware that there were some questions coming up in like the crisis work group about the ARPA state plan. I don't know if you folks have gathered those together and we want to schedule a particular session to go over those, but they need to come back into this forum because these have broader implications. So I don't know if there's a lot of them or if there's just a few.
I don't know what any of the questions are, so if you're getting questions from us, it's outside of my awareness of it. You can let me know and I'd follow up. I'd be happy.
Okay. So Carolyn, oh wait, do we have Brian here today? If not, Carolyn, can you connect back with Brian so that he can get those to me and we can tee him up for a session here?
Definitely. Thank you.
Thank you. All right. We've talked about that. Supported housing services. I know everybody's been waiting for us to be able to come back with information after we got our technical assistance clarification from CMS. We did not get an answer that we were hoping to get, even though the individuals mostly served by the community mental health centers have a targeted case management benefit that does enable the same organization to be the provider of underlying services, meaning the department submitted a state plan to CMS to take an exception to the conflict-free case management requirement under federal regulations, and we were granted that exception for this particular targeted case management. It does not cover over to the 1915I. Under the 1915I and the supportive housing state plan amendment that we have, the providing organization of the targeted case management cannot also be the provider of the underlying services, the supportive housing services. What this means is that we will need to have sort of a partnership between the entity that develops the supportive housing case plan and the agency that will provide the underlying supportive housing service. We don't see any way around it based on how CMS answered it and how we've researched the regulations that they referred back to. So we got this news like 2 days ago. We had an internal meeting about it yesterday. We researched the regulations that they cited there. And we desperately want to launch the benefit because we know people desperately need these services. But it is a disappointment to us, and now we've got to just work hard to try to develop a workflow that would allow that to happen. So one of the options that we have is to have a regional access point on the housing continuum, develop the plan of care specific to the supportive housing benefit, and then to make that referral over to the center if like the community mental health centers housing specialists would be the ones that you'd want to be able to do that, so provide that supportive housing service to. Another option would be the community mental health center case manager develops the plan and refers out to an external supportive housing provider to provide the actual, the underlying services. Jeff and Melissa, does those two basic scenarios ring true to you based on our discussions yesterday?
Sounds right. It sounds like there could still be a couple of options, but yeah, the answer that we got, the answer we needed, and it just wasn't the answer we wanted. The conflict provision does apply. So yeah, one way it could work is the RAP. Go through coordinated entry. Someone is they apply for the services. If they're already receiving targeted case management at a CMHC or another entity, that targeted case manager adds the supportive housing benefit to the plan. The RAP could then provide the supportive services. It could be reversed the other way. There are a couple of ways that it could play out. I think we are going to have a meeting with the RAPs very soon. They were hoping for a different answer too. So we'll need to talk through with them, since they are the starting point of the benefit, to talk through what's going to work best for them. And yeah, that's we'll have to work with what we have.
There's one exception, and it's really based on if a beneficiary doesn't have appropriate access to a provider, like if there was a region where there wasn't a qualified and willing provider to do either one of those services. Separate ones, right? So if you couldn't find 2 qualifying providers that were willing to provide the service and you only had one, that's the one exception, and we have to take the exception to CMS. So I saw
It's an issue of
Sunshine's
access. Yeah.
hand first.
Hi, Diana. I know I brought
Hi.
this up before, and I don't know if it's going to be a huge issue for this population specific, but I just want to talk about spend down and making sure that the other providers are educated on how to submit for spend down and that they are required to do that, because the last thing I want to do is lose services and then also have to do the spend down for them, so that they're the ones that are, we're essentially opening these patients for them so that they can bill and get paid. So is there a plan is that part of the education process? Are they equipped to do this?
It will be part of the education process. I just put it in the notes so that we don't miss that. But we do still believe that idea of an existing targeted case management service being billed first for those spend down purposes. So if they're one of your clients and they're getting targeted case management, if you folks are billing that first and that helps take care of their spend down, then it just makes sense that we would educate the supportive housing, the other supportive housing provider to advise them to bill afterwards, start those services afterwards. And remember, we have to do a prior authorization, so there will be an automatic, there will be, not an automatic, there will be a manual trigger in there that we can help navigate that with.
Okay, thank you.
In the event the center wants the housing specialist to provide the underlying service, that would be different. We'd have the regional access point or a different qualifying provider do the plan of care, so that the housing specialist could still provide the service. There may be a little wonkiness that we have to deal with, though, because of the sort of built-in prohibition about dual case management. But we might be able to use a waiver for that piece of it on the CMHC side. Kelly?
So obviously there's an impact to CLM because we are a regional access point and we are a provider. And so, but I'm just saying that because I'm not really commenting on it. I just want to park it and acknowledge that my silence on it doesn't mean it's not something we'd have to address. But what I really just wanted to reshare, I think I've shared it before, but if I didn't, we're also a provider of some DD services, and they have undergone a huge transformation in how they deliver services and authorize them. And much of the conflict-free case management is embedded in the framework of how they have to operate. And so they have service coordinators that do those plans. Some of those people are independent or they can be embedded in an area agency, but they have maybe something to look at. I think I've said it before, Jeff. You're nodding, so you probably have looked at it and aware of it, but just wanted to put it out there in case it's useful for any other region but mine.
Right, and see, that's part of the reason why we want to talk to the regional access points too, because we know we've already, briefed them early on about the benefit, probably, I don't know, maybe about 5 months ago or so, or June even. So we want to update them, but even back then, we recognized that there could be 2 regional access points that would need each other if one wanted to, if the person actually lived in that regional access points region and they wanted the regional access point to provide the underlying services, that regional access point would need a different regional access point to develop the plan of care. So they already knew they might need to tag team.
That would be
We-
especially in the case of someone who isn't already connected with targeted case management. If
Right.
they're coming in without services, the reps
Right.
might need to coordinate between
Right. We
one another.
knew if the individual was getting targeted case management under the 1915I, it absolutely had to be conflict free. So we've previewed that issue there. What we had thought we were able to do is if the 1915I was, if the targeted case management expressly took the exemption to the conflict free and it was paid out of a different plan, that we could get away with it, still be compliant with the 1915I. That's the part that's
Is-
brand new information.
Is there a free choice of providers? So is that
Yes.
embedded in? So an
Yep.
individual that's coming through might say, well, wait a second, I want my supports from CLM, which will then
Mhm.
create a workflow where I'm going to have to figure out, okay, well, who's the rep that's going to do my plan?
Right. And
Okay.
to, a point that Patricia raised, when we last talked about this, Manchester works with an extensive amount of the homeless population, and many of whom, for whatever reason, don't want to receive ongoing community mental health services. So you're trying to help them improve their living conditions, right? You're trying to help them get care, but they don't want to receive the care. They're willing to work with you on the homeless issues, right? This would still enable that to happen if you could provide the supportive housing service, develop that relationship with them, have the plan of care done by a regional access point, but start to begin that relationship. And then if they want to onboard with the community mental health center services, long term, you could transfer, essentially transition them over as a full client. And then at that point, you'd probably need to, if they were going to get targeted case management under your organization, which I don't know why they wouldn't. I mean, I guess if it wasn't medically necessary, then they wouldn't need to, but that's where you might have to relook at the relationship for the supportive housing service. And again, on both the transitioning and the sustaining side, it's about 150 hours a year. You can submit prior authorizations based on medical necessity to go beyond those hours. But, and ideally, it's not something that is happening over a 12-month period on a regular basis. But these, again, are things we'll have to navigate as those types of individuals will indicate interest in onboarding. Maureen?
Hi, thanks, Diana. So I have a really dumb question. I think I must be misunderstanding something. Are you saying that if we have a client who needs the supported housing case management piece, right? Like that we're gonna have to go to an external entity to have that like ordered for us to provide it? Am I
Yes.
understanding that correctly?
If you want to be the provider of the actual supportive housing, those 150 hours of services.
Oh, that seems really challenging.
Yeah, it's the same thing they're doing in DD, Maureen. You can't authorize the service and deliver it.
Yeah, I'm here. Yeah, okay.
Thanks, Kelly. I was just gonna say, welcome to the developmental services world.
Yeah.
It doesn't make sense
Okay.
necessarily, but it is what it is.
That seems so convoluted to me, but I guess we'll figure it out.
The slight difference is the under the DD plan, and correct me if I'm wrong, Kelly and Chris, it's not an authorization. It's essentially the care plan has to call for these services, and you have to attempt to connect the person to that provider. We don't have a mechanism in the 1915I that requires a specific authorization from that care manager. And Chris and Kelly, are they still, or do the DDs still have, the area agencies still have to develop like a specific budget for the services? And that's why you're using the term authorization?
Yeah, I don't know if I'd use authorization, but specific budgets, yes, they are required. But the care coordinator is the one who will, work with the providers that are chosen and get that information, basically summarize all of it, attach the budget and send it in for approval. The care coordinator doesn't approve it, the bureau approves it.
Okay,
Um,
right. So that piece of it isn't part of our 1915I, so at least you don't have to worry about that. Maureen, I think what ideally I would see your internal case managers doing is in the housing domain, you know, sort of addressing somehow cross-referencing their needs as associated with the 1915I care plan. You know, just
Yeah.
so you've covered it in your documentation for the CMHC's purpose, but you don't have to create the lift of creating the distinct 1959 care plan.
Okay, I just probably need to see it in writing because I feel like I'm misunderstanding something, but that's okay. I don't want to hold the group up.
That's okay.
I
That's
see it in writing, I can
yeah.
get a better, sometimes I just need to read it to understand it, I think.
right.
Yeah, I agree. This is confusing, and it seems like a lot of work for little return.
And with the answer that we got from CMS, I'm going to go back to the one-pager documents and the workflow documents and update them, and I'll hopefully get those out next week or the next week or the week
Great,
after.
thank you.
Right. I mean, we
That's great,
our
Jeff.
internal discussions was that we don't want to go back to CMS with any more TA questions on this. We don't want to hold up implementing. We've had the drafts ready since before we submitted to CMS, and we had internally said we'll update them once we get their answer. So that's going to move forward. And Steve, you know, I hear what you're saying about it may not be worth the effort. I'm really hoping the provider community, both our existing systems and our housing continuum providers, I'm hoping that although it might not be financially as kind of worth the lift, the individual's needs will prevail.
But we may be able to accomplish that with these existing services.
I'm sorry, Steve, you kind of broke up there. What did you say?
We may be able to meet the client's needs with existing services.
Correct. You could. But you could also potentially draw in some Medicaid revenue to help support the housing specialist roles.
Right, but whatever the organizations choose, Diana, we have to be able to be fiscally sustainable, so we can't,
Absolutely.
I mean, can't meet your mission if you're not.
I get it. I do get it. We're just hoping that we can still get some help out there to the organizations. And, you know, maybe when we were originally developing this application, it was with intention to try to braid the systems together to the degree possible. I don't know. I wasn't part of that. Okay, so we have 8 minutes left. Let me see what other updates we have. On peer support services, adding that, I think we've already shared the code. The pricing conversation went well. We shared the feelings that you folks shared with us last week about wanting the rate to come in for peer support services at the same rate as the existing baseline functional support services, the $27 and change. Leadership has embraced that. I have not heard of any turnaround for that, meaning refusal of that, and it works within the moment that we're at right now in managed care for Amendment 2 for the 1/1/25 billing period. So meaning it's seems like it's a nice fit. You folks don't anticipate any significant degree of increased utilization. They would just bill under a different service at the same rate. And you folks, you know, pending that, you know, once we will let you know when we put in the SPA, the state plan amendment package, because it will be, if it gets approved by CMS, it'll be retroactive to the date of application unless we submit it early enough to put an effective date of 1/1/25. Then it would just be retroactive to 1/1/25. But that is one one goal that was supported across the department, so across the leaders that have to weigh in on this. So that's
Can I-
good news.
Can I just clarify that if the guidance comes out later, you are not expecting that we will go back and
Absolutely not.
refund and rebill?
Nope.
Thank you.
Absolutely not. And no one has expressed any concern about continuing the ability to bundle the functional support services, even when we open up the peer code. So that was another good news part of the discussion. Targeted case management, we will be for substance use disorder benefit, we will be moving that forward as well. We've had no concern about, we don't have any concern about it coming in at the rate that is currently in place in other systems. It would be a per diem basis. It would not be a monthly targeted case management. So if you, for the centers that have SUD only programs, so they are not CMH eligible, they're SUD programs. The initial phase of what we're going to be launching there is the providers, the doorways providers are the key target there. How many of the centers right now would want to be an SUD targeted case management provider?
We'll be moving that way.
Nashua would want to.
Community
Community
partners.
partners.
I'm
Wanna
not
look at
quite
the
sure, Diana,
requirement.
when you say that, the same rate as our current case management, but per diem, how does that work?
No, in other systems.
Oh, in
So
other systems.
right, in other systems, we have per diem targeted case management already in the system. I know that you folks expressed an interest that for the, I think you did, that for the end, no, that was on the peer conversation. So yeah, it's for parity issues. We have to look across systems. I brought for the peer support, the exception there is that I shared it would be a parity issue within the existing system if we were to bring in peer support at a lower rate than what the peers are already providing for services. And that resonated in those discussions with the leadership. Under targeted case management, we would match the rate that is available in the other systems that have the daily form of targeted case management.
So that'd be like the CFI rate?
Yeah, I think it's around 50 something dollars, Chris.
A day? If you can make that happen, that would be sweet. I think it's lower than that, but
Wait, can
Well,
you
we'll take
repeat
50.
the
Jeff,
dollar amount?
you want to look up T1017 while we're doing this? I think the modifier, I think if you look into the CFI fee schedule, you'll see it in there. I think it's T1017 HF modifier. And then somebody else had a question. Go ahead.
I just asked if you could repeat the rate because my audio went crackling.
He's going to look it up to see what the published rate is right now. I thought it was right around $50. Chris thinks it's a little lower than that. So
50 sounds like for a week, maybe.
Diana, can I just ask?
Yep.
In terms of SUD case management, have we considered how that might work within the CCBHC PPS?
It's built into the CCBHC PPS, targeted case management for that population.
Okay. But would that mean then that we would just get our daily PPS rate?
Yes.
Okay, thank you.
Seeing T1017 under the CFI modifier HC, it's
HC,
5273.
Okay.
Is that per day?
It's per day, but they actually have to provide a service that day. So you don't get to bill it every day. You actually have to whenever you submit a claim for
Okay,
it that you've provided.
there must have been a change from when we initially started doing this and how that worked, so.
Okay, so occupational therapy, that's TBD in terms of when we can make more progress with that. The unbundling of the IROS, I think we already finished that discussion last week, and no one internally had a concern about even continuing the bundling. I just want to reiterate that. There are, community
gonna get-
reentry.
Are we gonna get written guidance on that?
Yes. Yep. In fact, I was just trying to finish the edits on a CCBHC billing code list document that I have to have for a 10:30 meeting today. And I intentionally put in there about the bundling would still be allowed for the functional support services. Yeah.
So when do you expect that we will actually receive written guidance on that and the 10-minute cap lifting?
So my goal was to have it to you 2 weeks ago. And
I
all of
understand
these,
that, but
yeah. So we're
we can't
gonna
do anything till we get it. So I'm just wanting to know.
I'm gonna get to it as soon as I can get it out the door, Jay. I can't, I don't want to give you a false promise that it'll be in 2 days. Do any of you so far have any challenges with prior authorization? What would normally require prior authorization to exceed the 10 unit limit? If there's any of those, that are coming up, let us know. And we'll try to hop on that right away on the PA issue. Steve, I know we're at time. What you got?
Really quick, back to OT. Did I hear you right a few weeks ago when you said we'd only be able to bill OT if it was part of a partial program?
Right. So it's a covered service as part of a partial hospitalization or no, sorry, IOP. If it's part of an intensive outpatient program.
So we won't be able to bill it as a regular service. It has to be part of partial.
Not right now. I'm just saying it's TBD because right now the top priorities are everything that has to be ready for 1/1/25. Because we're running out of time for those things. We have not changed our internal support for it. It's just we're running out of time. And we're out of time today. So we will, more to come, more to come. We are working our way through it all as best as we can. And I will put in a quick snapshot into the chat that includes sort of a quick down and pretty update on our work with the closed loop referral solution. We are actively engaged really on all sides of the centers, the rapid response work, the care traffic control, front door, the discharge side, the doorways, and with the managed care organizations. And I will give the EDs a deeper presentation at your next meeting. Thank you, folks. I hope you all have a wonderful weekend and a long weekend if you have a holiday on Monday.
Thank you.
Thank you, folks.